We welcome you all to Talk the Talk. My name is Janine Stiene,
And I'm Toni-Ann Antoniato.
the Masters of Myofunctional Therapy.
Together, we interview physicians, dentists, and other professionals to learn how their expertise can benefit you, your child, or your patient's speech and language skills and complement the services they are receiving. We welcome you to this episode of Talk the Talk. Joining us today is Dr. Kalli Hale. She is a dentist passionate about airway health and the connection between dental health and overall well-being. She practices in Texas, specializing in pediatric expansion and sleep-disordered breathing. However, she lectures and mentors around the nation, supporting the education and training of other dentists on the topic of airway health, an area she feels is not taught nearly enough in dental school. Welcome to the show, Dr. Hale.
Well, thank you so much for having me, guys. We're going to have so much fun today. So I can't wait to share all of that I have about airway. So
Thank you. Thank you so much. We're so excited to kind of pick your brain a little bit and go into some topics. But if we could start with you just telling the audience a little bit about you and your journey and your why. You know, obviously you have said that this isn't something that you learned about in dental school. So what brought you to this path and made you kind of this more airway focused practitioner?
Yeah, I would love to. So I grew up in dentistry and my parents are dentists. I'm married to a dentist and my younger sister's a dentist. So there's literally 5 in my immediate family. Okay. And airway dentistry definitely was not a thing early on in my life. Working in my parents' practice, even as a teenager, you know, back when charts were paper and you're filing them. And I was the little voice on the end of the line saying, you're due for your checkup and cleaning, you know, just like your wonderful family sort of general practice. And when I went through dental school and got out, I had such an incredible journey, just being able to work in family and have somebody to help you get out of those things, those situations when you get into them as a new provider. But somewhere in there, I started hearing this buzz about sleep apnea, and I knew nothing about it. I had, like you said, no training whatsoever in dental school, aside from just kind of a general understanding that it existed as a diagnosis, and you had to be obese to have it, which we know is not the case for patients. But I mean, myofunctional therapy would have been like a foreign word, like a different language. I have no clue. Like that was never, ever anything that I had even heard of before. And I slowly started screening for sleep and not even treating it, just, oh, you have it, go to your physician and get a CPAP. And this movement in the last, I would say 6 to 7 years has been absolutely incredible with the awareness and the knowledge of airway dentistry and myofunctional therapy, and just how dentists and myos need to be working together so tightly. Like, was just a very foreign concept, you know, until now. And now I have lots of dental practices in Houston. It is a family affair. And we have myofunctional therapists in all of our locations. Like, it's just like an absolute need for us to be successful for these patients and to get them the care that they need. So yeah, I mean, I started just drilling and filling teeth and making crowns and pretty smiles. And now looking back on where I started and what I do today, which is little to no general dentistry at all. It's all airway expansion, pediatric and adults appliances. It has just been a wild ride. Really, it has. And it hasn't come without its trials and tribulations from people that don't agree with what we're doing and what we're talking about. But I don't care because it's all about the kids.
Absolutely. Yeah. Are there certain things that you tell a parent that they should be looking for if they perhaps have a child that is suffering with sleep disordered breathing? Are there certain signs and signals that you're asking them to look for?
Yeah, absolutely. Well, in my practices, in my clinical life, they're filling out a ton of paperwork regarding it. I mean, we use the validated sleep questionnaire for all of our pediatric and adult patients. So they don't come to see me now without having filled out that information. So it is a requirement, actually, in order for me to go have a conversation with you. In the early stages, when I was just starting to screen and didn't know anything, that was the one thing that I changed. I wrote an article at the beginning of this year for the Dental Sleep Practice magazine, and I titled it The First Thing I Changed, which was doing a sleep questionnaire and just opening the door for conversation with these families. But on social media and stuff that I'm posting to try to help get people aware and asking their own dentists and their own providers is your child grinding their teeth or snoring? Those are the 2 things that in dental school I was told to tell a parent was normal and they would grow out of. I mean, that was literally the narrative.
Wow.
And it's one of my biggest regrets because it's not true. But it was what I was told. So, you get out and I did have wonderful professors in dental school and I had very well-meaning people. But if that's what everybody has been told and told and told for a very long time, that's just what's going to get told. And it's what we're going to repeat as a young dentist coming out of school. So that is definitely something I hope to change with the doctors that I mentor and with the information that I'm putting out on social media. But for parents, I'm like, if you're mouth breathing, if your child has speech issues, if they're grinding their teeth, if they're snoring, please ask more questions and get a second opinion.
Absolutely. Yeah. We, obviously are looking at those things too. We have a very detailed case history and looking for those also because it means so much more. And we're always saying, like, just because they say something is common doesn't mean it's normal. And there's
absolutely.
Yeah. And I feel like we're always up against, like, we're the speech pathologist versus the dentist or the pediatrician. So, right, wouldn't you say that, like, normally if the pediatrician or someone is saying it's normal, then who are we as the speech therapist to come in and say,
it's like you versus the doctor, right? Yeah, absolutely. But I feel like that just goes to show how behind medicine is. Like, we're very behind. I mean, even in airway dentistry, was just at an amazing conference in San Francisco, the World Dental Facial Sleep Society meeting, listening to lecturers from all over the globe that are frankly ahead of us. They are. But so it's so hard because you got to find your people. You got to find your providers that are even up to date on the literature. And we have similar issues like you guys do commuting with doctors. We have similar issues as the dentist trying to communicate with orthodontists or pediatricians for sure. I mean, you said it. I will back you up on that. It has been a wild experience with this resistance to acknowledgement of tetheral tissues. I'm like, okay, well, they're there. So whether you understand them or not is a different thing. So, it's just been this crazy thing. But I think in all of the avenues of what we're doing, I truly do believe at the end of the day, most people in whatever profession that they have do mean well. Like we want to help our patients.
Right.
But we also have to stay on top of the literature.
Yeah.
And if a dentist and an SLP OMT is telling a patient that their child has a tongue tie and needs to be addressed, for the medical provider to go opposite of that without maybe even a phone call or a conversation, that's where things get really frustrating for me. Because had roles been reversed, I'd pick up the phone. Hey, I've got a question. You suggested this. I'd love to know more. Why is this something that you think needs to be done or whatever for the patient?
Absolutely. Couldn't agree more. One of the things that you're also very passionate about and speak on is the ADHD side of things when it comes to supported breathing. So tell us a little bit about what you believe when you have a patient who either has a diagnosis of ADHD or they're presenting with symptoms, with attention difficulties and sleep studies.
Well, I appreciate you bringing that up because that seems to be the biggest traffic on social media right now. I had this one reel go absolutely viral about ADHD, which has come with some educating moments of commentary in the comments because I didn't realize how controversial it was to say that there could be a root cause for this problem. And there absolutely is a root cause for this problem. And my whole point and my whole heart for talking about it is to just have another opportunity for parents to leave no stone unturned. If we know, and we do in the literature, that the misdiagnosis rate is upwards of 50% between the child that's sleep deprived and a child that has ADHD, I have never met a parent yet that hasn't been very eager to just make sure that there isn't a solution that is very simple, like dental arch expansion, myo, and nasal breathing for their child, especially if they're on medication. I never, ever, I'm not here to judge a family that has made that decision. By the time they find me and they are on medication, a whole lot of hurt has happened. A whole lot of stress for that family has happened. And if I can alleviate that in any way by figuring out that there could be a solution to the problem, that family deserves it. So I'm not here to say every single child with ADHD has OSA, but I will tell you it is absolutely the number one side effect of a child with a diagnosis of ADHD.
Wow. Wow. Who is administering the sleep studies? Are you administering them? So here, in New York, we're starting to see the dentists are providing these sleep studies, which I think is fantastic because a lot of times you go to the ENT and the ENT doesn't feel a sleep study is warranted. So we never go a step further. How does it work by you?
Yeah, so it's actually dictated by the state. So in Texas, I can do it. There are a few states, maybe only 2 left, that the dentist still cannot provide that screening tool,
Wow.
which is just mind blowing because, I mean, we can literally inject anesthetic into your, vascular system, but we can't just, hey, take this ring home and let us screen you for sleep disorder breathing. So yes, in my practices, we have them. I have very many of the machines, and we are the first line of take this home, let's get a baseline. And we get beautiful results with our home sleep apnea tests. And one of the leading sleep physician, neurology, triple board certified, maybe you guys have heard of him, Dr. Gerald Simmons, is here in Texas with me. He's in Houston, actually. And so it's a great resource for me because if I get some data from my sleep test that I'm not super happy with, or we're having trouble with connectivity, sometimes on a home sleep test on a baby or a child, it's really difficult, and we need something more more thorough, like a in lab study, then we'll refer for that. But yeah, here, luckily, I can do it and I can screen them. Now, we can't provide the diagnosis of sleep apnea. No dentist can across the United States. So we do work with every single sleep study that we do gets read and interpreted by a board certified sleep physician because they're the ones giving the diagnosis. I'm just helping you fix the problem.
Got it. And then from there, they take the results to their ENT and talk to them about.
It depends. So once the physician has given us the letter of medical necessity, there's usually a laundry list of options that are in there. So if the patient is seeing me and I've identified malocclusion and underdeveloped arches, so maxillary mandibular hypoplasia and inability to breathe well through their nose, then we can start our orthodontic care and do what we need to do on that end. It also depends on how severe the case is. So it really depends if we're talking about kids or adults. With kids, it's very much orthodontic and myo. And on occasion, if we need tonsil and adenoid referral for possible removal, I'd rather expand first and then see what we get. But if we need that, then yes, absolutely with ENT. But with adults, it's a little different story. I mean, if we've got deviated septum and enlarged turbinates and we need a lot of other stuff done, I always tell them it's not the Kalli show. Like, I'm going to get you all the right people so that you're not hitting any brick walls when I'm telling you need X, Y, or Z. And you still traditionally need orthodontics or traditional oral appliance therapy, but we might still need some help for our nasal breathing and our tongue posture because that's not something I can help them with.
Got it.
Yeah.
All right, I'm going to jump in. Well, I have one more question. Can I jump in?
Okay.
So is there an age that you're starting extension when you're noticing that the sleep disordered breathing is at least is an issue, or they're presenting with some type of sleep apnea?
A birth. I mean, so I'll evaluate for tethered oral tissues, a few days old. I have lots of beautiful IBCLCs that refer to us just so we can make sure. Sometimes they're like, I don't even think there's a tie. I just want your opinion on if there's a tie. When it comes to the pediatric stuff, I am very loud about early intervention. It is the most critical thing. I was actually the conversation for most of the weekend at this World Dental Sleep Society. So anybody that's against starting when the kids are all in primary dentition is just really behind on the literature. And that's all I got to say about that. Okay. So when they're young and I can identify underdeveloped arches, tongue posture, mouth breathing, and typically just no primary spacing, like the baby teeth are all touching each other and we obviously have a space issue, then I will go in with a myofunctional style habit corrector appliance. I will start very young with that, something non-invasive that's promoting 2 things, nasal breathing and muscle redirection. If I can get them breathing through their nose and get their muscles redirected, I will see incredible results with their expansion at the same time. So while people love to say that's not an expander, I'm like, yeah, no, but it's one of the best ones you can have because your body's doing it yourself, Right. When they come to me too old, and by too old, I'm thinking like 9, 10, 11, 12, 13, 14, 15, anything around there where we have a lot of growth that has happened with no redirection of muscles and breathing, then we have a tremendous amount of malocclusion. And that's when I have to go in with expanders and reversible headgear and all the consults and referrals that we need to have, because I firmly believe that decision and that treatment for that child in that moment, whatever we do from getting them to underdeveloped to not, is the single most important thing that they will go through as a child. It's going to change who they are as an adult. And so I don't want to miss our window, but we start as early as possible. Yeah.
Okay. Yeah. I think as speech pathologists, obviously early intervention is like drilled into us throughout our entire skill, our entire schooling.
Right.
And then when it
Yeah.
comes to dentistry, we have
It's
that
not.
thought of in our minds, but then we have dentists that are like, oh, there's still too many baby teeth for us to, do anything right now. And it's like, but we see it because we do have myofunctional patients who are 4 or 5 and they're going through these
Yeah.
early growth guidance appliances. And it's just so much easier at that age. It's so much, those muscle memory patterns are
Yep.
not as instilled in them. So we could change things faster. They can expand faster, all the results we want to see. But then we have a 14-year-old who we look in their and we're like, this is such a high narrow palate, and they've been through expansion a year ago. And we're like, what did we
Oh,
expand?
right.
Like this
right.
is not an
Absolutely.
expanded palate.
Well, and I'm so glad you brought that up because I'm curious. I'm going to tell you why I think those cases look like that. And I'm curious to know what you guys, how familiar you are with the expander protocols that I do and I was taught, which differ from upper only. And so yeah, there's so much there. I have done many second opinion consults on families that have already paid a lot of money for phase 1 ortho. And I'm looking at an intramolar width that isn't even appropriate for a 6-year-old and the child's older than that. And one of the biggest missing links in our expansion journey, one is dentists being any sort of aware of muscle driven expansion. So you're fighting an uphill battle because you guys are taught very early on, don't ignore any speech issues. We need to start very, very soon. By 3, you're too late. Like, get us in before. Whereas in dentistry, we're taught to wait till the baby teeth fall out.
Right.
So I wouldn't be referring to any of those doctors that are giving you guys an uphill battle at all. I would be telling the parents actively, you need to get a second opinion, which I know can be a little bit awkward. But like at the end of the day, if we aren't the ones telling these parents that this treatment can differ and they should get a second opinion, who's going to tell them? Like, and I do feel it's my duty, while I am always very respectful of whoever the provider was at that time. We are at this point in time right now, this is what I'm seeing, and this is where I feel like we should be. So this is what we should do going forward. So one of the biggest things in my training was you have to do both arches. You can't just expand the upper and get enough that you need for a full tongue space if you don't do the bottom. And so all too often they've had an upper expander only, which is known to fail. And I learned very recently that their protocols for upper only is 2 millimeters. I don't know if you guys knew that.
No.
It's 2 millimeters.
Okay.
Yeah. And I'm like, wow, unless there's a crossbite, if there's not a crossbite, it sounds like it's 2 millimeters is what you get. We're pushing kids 10 to 12 millimeters. I mean, the only way you can do that is by doing the lower jaw at the same time in a developing, growing child so that it's safe. And that's where the rubber meets the road for me with the amount of cases I've done and things that I've completed that other providers said the only option was to pull teeth. And I was like, no, we're just not going to do that. Like, we are going to figure this out. And if we do both jaws, I'm confident that you can have all your teeth. And I'm forever grateful to those families for letting me do it so that I can prove it. You know what I mean? Because I'm like, there's a very specific way of doing it, which is really the difference in the success of the care by the time they get in y'all's chair and they're older.
How do you think we can streamline the course of treatment across dentistry in terms of early intervention and pediatrics? Because I do feel like depending on where they went to school or who their mentor could be or their school of thought is just so different,
Right.
which again makes it very challenging for us because it's, you have to find the provider that's
there's not like one way of doing it. Right.
There's no standard.
Well, so I think finding like you guys having a general consensus and opinion on how you want the expansion done, even though you're not a dentist, but you have all the understanding in the world of muscle activity and what you need that tongue to do and where you need the teeth to be. And your provider selection needs to be accordingly. Like, you need to make sure that whoever you're referring to even knows how to do lower jaw expansion. And I've got plenty of resources for finding the right people. People are DMing me all the time in certain states. Like, who do you know here? You guys know I built a company called Tooth Pillow, which is really just a teledentistry platform to increase access to the care that I do with these habit corrector appliances. Now, in the older age kids, it's really difficult. Most of the time I have to deny them, which is really, really sad. But if they're too severe and they must have custom fitted expanders and you're cranking it, then I've got to find them somebody. So when I embarked on this journey of creating this company with a couple of really incredible people, it was, how can we find the best minds in the world, but definitely in the United States, so that we can tell these kids exactly where to go, or these parents exactly where to go. And so for virtual treatment, I mean, that's one of probably the easiest things for you guys as you're looking for somebody, but it's just making sure that it's what you want the patients to be in. So a habit corrector appliance, for example, between the ages of 3 to 7 is every single kid, no matter what, as far as I'm concerned, because we need to have the tongue up and the lips off the teeth. And that's how these appliances work. We use a couple different brands. If I approve the child at 8, 9, 10, or 11, it's because I really do think that that's an appropriate thing for them right now. Might not be the only thing they need. And we never tell them like this is going to replace expanders or braces or whatever, but it's the most important first step because I want to make them nasal breathers. And it's the best way to do that. So I'd say for your little patients, you could definitely send them to the website and they could get evaluated by their state level provider that we've hand selected in their state to make sure that they have the right appliance. But then when it comes time for upper and lower expanders, then they would need to see that person or somebody, that you guys have vetted that you think is appropriate. So, depending on your opinion and what you're thinking you're needing on that case, I mean, obviously, virtually, we can handle a whole lot and just conversate with you on what we're seeing. But when you're doing habit corrector appliance therapy, you get incredible expansion, but it's slow. And so that's the difference in what you guys might need that you're wanting to kind of speed things up, where I'm like, we need a couple, 6, 12, 18 months before we're going to see a really big change in the palate sometimes. But it is still an incredible way to get that tongue where it needs to be and get them nasal breathing.
And do you see a lot of your patients through tooth pillow or through your own private practice? Are you seeing the importance of myofunctional therapy being tied into the expansion journey for the?
It's critical. It's the difference in the success of the case long-term most of the time. Now, I can't force people to pay for myo virtually or in office, but like I told you, I've got a brand of offices in the Houston, Texas area that's called the Airway Dentist, and myo is an absolute must in these practices. And so as we're navigating that together, I've gone a lot more aggressive over the years. I'm like, if you want the kind of outcomes that you see me posting on social media and what my before and afters look like, you got to put the work in at home. You've got to do myofunctional therapy. You've got to wear your tooth pillow appliance. And anything else that happens in between is just noise. You just have to make sure that your child does this because the getting from A to Z, getting to Z is what matters. I don't care if your expander falls off when you're eating popcorn. It sucks. You got to come back in. We got to glue it back on. Whatever the situation is, we just have to get the kids finished.
Absolutely.
You recently had an experience where someone challenged the term airway dentist, right? Because it's not.
Oh, really? I got a whole brand of practices called that. So give it to me. Let's go.
Yes, it was just that, there's no such thing. There's no that's not a profession. They're dentists.
Oh.
And it's like, okay, well, they, have decided to take their career in a path that is more whole body airway. Like they don't look at teeth and just think these teeth are supposed to be straight. They look at a mouth and think, what is happening for this entire individual's body?
Yeah.
Do you think that will come?
It's already here. They just wish it. Yeah, no, it's already
very aggressive. It wasn't that aggressive. I meant, do you think it will be a specialty, like that it will come?
Yes. So I do. That's something that I may be retired before that ever happens. But there are some really incredible certifications that doctors can get. So, like, I've got my diplomate with 2 different sleep boards, and no, it's not considered a specialty in dentistry. However, most dentists won't touch a mandibular advancement device with a 10-foot pole if they hadn't been trained on it, right? But it's not something that's a board certification specialty in the state of Texas or anywhere else that I'm aware of. However, the commentary of just that's not a thing, or it's not, they're correct. It's not a specialty. You've got ortho, perio, general dentistry, oral surgery, anesthesiology, and pain are the 2 newest ones. So there's definitely more and more change when it comes to people who have spent their life being an expert, which is what I call myself, an airway. Yes. I am an absolute expert when it comes to this stuff. And I've done everything that I can possibly do to make sure that you're in good hands and that these kids get the care that they need. But it's not a specialty. But also, if you don't know about it and you don't treat it, then please don't have an opinion about it.
Exactly.
Agreed.
Because you're going to tell the patient maybe they don't need something that could have long-term effects on the way they turn into an adult. And that's where I lose my patience. Because if you're willing to tell a child a snoring is normal or their grinding is normal and they'll go out of it, that is doing harm, in my opinion.
Yes, absolutely.
That's great. Okay, so one of the things that we also love when we saw you say it or in your social media was that you said a mouth breathing child is an unhealthy child. And
Yeah.
I think that, might sound in some ways like, oh, is that a harsh statement? But that's such a powerful statement of parents realizing how detrimental mouth breathing can be on their
Yeah.
child or even on themselves as an adult. So tell us a little bit about that.
Yeah, when I made that post, I have a great team that helps me with my, ideas for this and my social media. And I wanted a one-liner statement that would hopefully evoke a little emotion because, and that's the whole point is ask me why you're not a healthy child if you're mouth breathing. And there's plenty of evidence. This isn't, I mean, anybody could Google it and get a laundry list of reasons. But just as far as airway dentistry is concerned, when you're mouth breathing, you actually get less oxygen to your brain than you do through your nose. So from a child neurological developmental standpoint, even adults, I don't care, but definitely from a child of a developing brain, the last thing we want is less oxygen. And one of the leading physicians, Dr. David Gozal, I've got his giant textbook here next to me. I'm just a nerd with this stuff. I read it all the time. Will tell you that they're seeing that some of this neurological impairment that kids deal with early on regarding obstructive sleep apnea and low oxygen is not reversible. So to know that there are people that are studying this in a way that isn't going to trickle so slowly to dentistry if you're not looking for it, then I can't not yell about it because it's about the livelihood of our kids. And if I'm not yelling about it and I hopefully maybe making somebody mad or having them DM me and ask more questions, like who's going to? And so mouth breathing is terrible. You don't have a mouth breathing adult if you weren't a mouth breathing child in most instances. You're going to snore more. Your adenoids and tonsils are going to be more swollen because the air coming in through your mouth is not filtered, warmed, or humidified, which is literally the nose's job. So I am all about nasal hygiene. I love the intake breathing strips. Those are my go-to for patients that struggle with like one side or the other that doesn't breathe well. I exercise in mine. I do so much more like when I'm at the gym if I'm wearing that thing. And anyways, it just breathing through your nose is a critical aspect of our childhood, and we need to be nasal breathers. We were designed to be obligate nasal breathers. And if I can do anything to make sure that that kid's going to sleep with their mouth closed at night when they're an adult, we won,
Yeah.
Absolutely. Yeah. A lot of what we talk about.
I know. I can feel your passion. Like as you're talking,
thank you.
I can feel my heart rate increasing.
Oh my God.
I'm feeling empowered, I guess is what it looks like.
Well, I'm so happy. I hope so, because you guys are critical to how good our cases look. Like truly, when I was at this conference this weekend, there was some incredible oral surgeons showing what they can do for double jaw surgery. I mean, when it gets to that point. And I'm very thankful for medicine. And I'm so thankful we have surgeons that can do that when we get missed as kids and we turn into adults that are really underdeveloped. But he showed this one case, and I'm sure you guys would just be like jaw dropped, but she had double jaw surgery twice by the time she was 19 years old.
Oh my goodness.
And the reason was because it would fail and her anterior open bite would come back.
Oh.
You know what I'm thinking.
Yeah.
Now, this surgeon, by the time he took over, her condyles were totally worn down. She needed total joint replacements at like 21, 22 years old. And he's a huge proponent for myofunctional therapy. He got her in myo really quickly. But I'm like, of course it opened up. If you don't pay attention to the muscles, you can break your face and put it in all sorts of places. But whether it's going to be stable or not is going to be dictated by how you breathe and what your tongue is doing.
I know.
So to see that this poor child, I mean, it's just awful, had gone through that twice, and you're looking at a bite that does this. I'm like, what's the missing link here? Because it wasn't like that when they did the ortho and the surgery. And he said, ortho's blaming the surgeon's blaming the ortho. And I'm like, did anybody talk about the tongue?
Yeah.
Right.
For real.
Absolutely. Yeah. You said in the beginning of this about how in the last, I think you said 6 years, that change in the field. And we've been saying the same thing, even locally. When I first started working with Janine, which was 13 years ago, we barely ever got a consult, like a recommendation from the orthodontist. And now
Wow.
it's our leading referral source. You know, most of our myo evals are from
Good.
orthodontists.
Yeah.
And we
Yeah.
definitely see that huge change, which does, you know, is inspiring because we do a lot too with like lecturing and teaching and
Oh, that's
yeah.
beautiful. Oh
So
my
it's
gosh, that's
nice to
great.
see that movement for sure.
Yeah.
Definitely. And I
Yeah.
do think so much has changed. We used to only hear palate expansion when they're in crossbite.
Yeah.
We heard that. Yeah. So much.
Yeah.
And now we're starting to hear the looking for room and looking for space and, you know, wanting to give more space for,
Totally.
which is really wonderful. It really has.
Yeah.
It's really wonderful.
Yeah.
What do you feel needs to happen in order for the world to be more aware?
Honestly, I think there just needs to be constant conversation. And when I built Tooth Pillow, I was like, I'm going straight to the moms. Because if I can tell the moms what's going on and they can demand the help and the service or find somebody else that does it, that is where I feel like we have the biggest impact right now is in our communities. So when I was first starting this out and started having this reputation of doing things differently, I was very holistic in my mindset of treating patients and making sure my materials were really safe and the whole fluoride discussion and airway. It became this chatter in neighborhood Facebook groups and just other generalized health Facebook groups in my town in Houston. And the more that patients would like trepidatiously come in and see what it's all about and meet me, the more they would talk about it. And still to this day, in my main airway location where I'm at a couple days a week, our word of mouth is our top referral source every single month. And so I was like, okay, I don't need to go to like Facebook ads, Google ads. Like I just need to talk to moms and be like, hey, is your kid bedwetting? Are you dealing with your child waking up a lot at night? Are they really cranky? Are they doing bad in school? Like maybe their sleep is bad. Like maybe I could tell by their jaws, like come in and let me take a look. And then we will find all this malocclusion and all this mouth breathing. So yeah, anyways, I could go on and on about it, but that's just to me, it's so important when we're trying to identify like how do we make the biggest impact? And I feel like we go literally to the moms and the dads, of course, but like
Yes.
just direct to the families because you know, I don't know. Like when I was at this meeting, I came back super fired up because I'm like, there are lots and lots of well-meaning airway doctors around the globe, a lot. And it was so rewarding to just be in the same room with hundreds of people that do what you do. And we can all just be like, we're in the trenches together and this is great. And we look at this case and we're all just swiping on our phone. Look at this case. Can you believe we did this? And like, so that movement is happening. I think in the next 10 years, it's going to be a completely different discussion. And there's enough really incredible orthodontists that are teaching now, which is important. Mike DeLuke being one. I was on his podcast recently. I don't know if you guys are familiar with him. Outstanding information. And he has been doing this a long time because he just so happened to have a mentor in his residency that was helping him out to understand how to do it. So, and he's getting a lot of following right now too. So I think, again, just the more awareness there is that it exists, the more impact dentists will have because they're going to have this demand. You either learn it or you don't get the patients.
Right. Oh, that's great. You don't know what you don't know, right? But
That's true. Absolutely.
that we will get them to know it.
Absolutely.
So another question for you. We clearly like your little one-liners. So another one for you. You have, and you've said this, I think I watched one of your reels and just seeing the passion in your demeanor when you say this is that we have to start doing it right. We have to start getting things right for the children. That's, you know, just so powerful and you're so passionate about that. And what in your mind is that getting it right? Is it the early intervention? Is it the type of intervention? What do you want for that?
It's early for sure, but it's the type. I think when I first started saying that, and I've said that for a couple of years now, just we're not a healthy society. Our kids are not healthy. We're like one of the sickest, I would say, like of when we're looking at all the nations. And I'm like, I'm so tired of kids being medicated for being tired. And I'm tired of them being told that things that are common are normal. And they're not normal, just like what you were saying earlier. And so when I say that, I'm hoping it induces some thought for moms and dads across the country that they should ask more questions. Like, oh, have they been doing something wrong? Because we have. And in my opinion, not doing upper and lower jaw expansion has been where we've been missing it. And of course, the myo link, and of course, the early intervention. But if you're going to go spend a whole bunch of money on braces, if you don't have any idea that the way those braces are done could potentially harm your kid, that's a problem, in my opinion, especially when it comes to taking out teeth and retracting.
Yeah.
So I say stuff like that in the hopes that people will feel my passion for this and want to know, what do you mean? Which is exactly what you asked me. So I'm so happy.
And that's exactly how we found you.
Yes. I appreciate that so much. Yeah.
So what does your mentorship program look like?
I love that you asked that. So little over a year ago, maybe about a year ago, my husband was like, you need to teach this stuff. I actually was a very competitive piano player growing up. I don't say that very much on these because it usually doesn't come up. But I taught piano lessons in high school until I bought my first car. I had a 2002 Honda Accord, and it was $4,000. And my mom and dad, obviously paid for it and then charged me interest, man. Like I had to pay them with interest. You got to learn how to do that early on. So yeah, it's been a really interesting journey for me from start to finish, but having mentors in my life has changed, the way I look at life in dentistry, from practicing with my parents when getting out of dental school and having my dad catch me anytime I was going to fall, with whatever it was. But my husband was really pushing me to teach. He was like, I had been teaching for the organization that I initially was trained with, which is Vivos. And I had been helping them a lot with, hey, somebody has a case question. Would you mind guiding them? And I'm like, absolutely. Like, we got to save all the people. Like, yes, what do you need? Like, and so I just decided that I wanted to take the reins and really help people to be successful with this in their practice, because the fact of the matter is, where this fails in dentistry is implementation, unfortunately. And I think that goes with almost anything new somebody's bringing to their practice, whether it's implants or some new technique, endo, whatever it is. But implementation is where it failed. And I was having such raging success because of my ability to communicate and tell these moms why they need it, and what, and also how to lead your teams, my hygienists, my assistants, in a way that would make them equally passionate about what we do at my office. It can't just be the Kalli show. And so that's where the Sleep Well journey started. And so my husband and I started a podcast first. It started out as the Sleep Well journey, and we just got on and ranted. There's a YouTube channel with it, and you can see us just bantering back and forth about how dumb dentistry is with these old techniques. And gosh, we had a blast, and we're still doing it. And then when he told me to start mentoring, I was like, who is going to sign up for me? I'm like, what? And then all of a sudden, all these people were like, yeah, when and where? And we meet twice a week. Seriously, 2 times a week for the last year. And we go through everything, like case troubleshooting, employee stuff, like all the nitty gritty. And for me, just helping them to stay focused and stay on task with how life-changing their services are for these patients is like tremendously rewarding. So yeah, I teach them how to do what I do in a very predictable and safe way, so that they can avoid all the pitfalls I had early on when I didn't have anybody to ask about, all of this stuff. And it's been super rewarding. Yeah.
Wow, that's amazing.
That's great.
Thank you.
And you have a website that obviously, if we have any dentists or providers listening, they can come to your website and be able to learn more about how you might be able to support them.
Absolutely. Yeah. So we're the sleepwelljourney.com, and there is an entire tab for mentorship where they can get more information, and they'll be connected with my education coordinator. Her name is Marissa. She's wonderful. And then, yeah, if you are on podcasts or YouTube, you can go to the Sleep Well Journey. Last year for season 2, I interviewed a whole bunch of providers. It was really awesome. And it was a fun variety of people, actually, just to pick their brain, like you guys are now with me on like, what do we do with sleep apnea? And how I interviewed a cardiologist who was absolutely incredible, and his wife's an airway dentist. So that was a very unique conversation. So yeah, I'm easy to find it on Instagram. I'm the Airway Centered Dentist, all spelled out.
Perfect.
We love it. This was so unbelievable. Like, I feel like I could probably talk to you for another 5 hours.
Same.
I just feel like it's like, okay, what about this? What about this? How do you feel about that? No, it's really been so educational and enlightening, but I think it's going to be enlightening to our families and our patients that are hearing it for
I hope
the first
so.
time, or they're like, oh my God, I'm in braces and I probably shouldn't be. We're hoping that's not the case. We're going to hope that it's the opposite. But I think, no, I really think it's going to be helpful. Thank you so much.
Yeah.
Well, you're so welcome. I appreciate you guys having me on. It means a lot.
Yes, thank you.
Thanks.
Thank you for joining us on this episode of Talk the Talk.
We hope it was enjoyable and educational and further supports you both personally and professionally.
For more information, please check out our Wyo Myo and Myo Minute podcast, as well as our other episodes of Talk the Talk. And don't forget to check out our tongue training appliance, Spot Pal, to help with tongue thrusting, thumb sucking, snoring, TMJ, mouth breathing, and so much more. Visit thespotpal.com.